First, the peroneal tendon anatomy. Both peroneal tendons run behind the lateral malleolus. The peroneus brevis tends to run in front of the peroneus longus, and both run under the peroneal retinacula. Occasionally a peroneus quadratus can be present, so watch out for this additional muscle which you'll see. The sheath itself consists of the superior and inferior peroneal retinaculum. The superior peroneal retinaculum starts above the ankle about 4 to 5 centimeters above the tip of the lateral malleolus, and it forms a fibroosseous tunnel. The inferior peroneal retinaculum is on the lateral wall of the calcaneus and is continuous with the extensor retinaculum. The peroneal tendons sit on the lateral wall of the calcaneus, and both have a separate fibroosseous tunnel with sometimes a bony protuberance in between. The brevis goes forward to the base of the fifth metatarsal, and the longus passes underneath the cuboid via a sesamoid bone, separated by the peroneal tubercle. When taking a history, you want to know where the pain is located, if there's any associated instability. Often the injury occurs in a sports injury, such as illustrated here in skiing, or in soccer, ice skating, or basketball and football. Often the athlete will be aware of something giving way on the outside of the ankle at the time of injury. In some cases, the peroneal retinaculum is elevated off the bone, as a grade 1, as illustrated here from Coughlin and shown. Or it can be torn off bone with a cartilage fragment. Or it can be elevated off bone with a bone fragment being present that can be visible on X-rays performed preoperatively. This is an example of physical examination, and you can see as the patient everts the foot against resistance, you can actually see the peroneal tendon sublux just there. And then going back into the groove, subluxing, and then going back into the groove. On CT scan, you may see a shallow fibula, a flake sign of the fracture fragment, or dislocated tendons, and in this view you can see just lateral to the fibula, the peroneus brevis being outside the groove. Ultrasound is useful on occasion as it's a dynamic test, and as the patient everts you can actually confirm the dislocation. This is a CT scan demonstrating a dislocated tendon and a shallow groove. There's numerous techniques for repair, including bone procedures, retinacular repair and isolation, or retinacular reconstruction. My personal preference is to deepen the groove and then repair the retinaculum, as the groove is often shallow, and deepening the groove will allow you to ensure that the tendons remain reduced after the. This is a surgical case. You can see the lateral incision, similar as you'd use for an open reduction. You can see that the large patulous sheath, which the tendon was dislocating into, and then coming through this, we're able to dislocate the tendons anterior to the tip of the fibula where there's a shallow groove. What I like to do is use a saw to cut up on the fibula just behind the lateral malleolus and up quite a distance up the fibula, about 4 or 5 centimeters. And then about a centimeter deep, repeat the second cut up the length of the fibula, so that this allows us to impact the bone in to form a new groove. A saw is nice to use for this. It's hard to get a cut with an osteotome, as it may fracture out. I then use a drill on the top end to form a back cut so that we can impact the bone fragment. On occasion you might want to get a curette behind this to actually impact some of the cancellous bone so that you can then hit this down. The best impactor I found is the bending iron from the small fragment set, which makes a nice surface to actually impact this in, as you can see here, forming a new groove for the tendons to sit against and hopefully prevent subluxation. You can then confirm that the tendons will remain behind this groove, as you can see here. I then make drill holes through the cortex of the fibula so that we can repair the tendon sheath back. The tendon sheath has to be identified and advanced so that it's no longer loose as it was before. I'm using a number 2 non-absorbable stitch and then passing it through the bone to repair the retinaculum, and repairing it underneath so that the tendons can't come back up onto the tip of the fibula. The loose segment of the retinaculum is then repaired back down, in this case using a 2-0 absorbable stitch, and this is what the repair looks like by the time you've finished. The skin closure is then performed. You can also evert the foot and confirm that the tendons don't dislocate any further. The outcomes are a little hard to find, but in general it's a good operation. In the case of the dislocating peroneal tendons, there's reasonable evidence that the repair should be performed, but there's not enough good quality outcome studies. However, my personal